For example, this is from a publication of Vyas in 1996. Here you see a basal cell carcinoma of the face, and here you see the adjacent skin of the basal cell carcinoma, and what you see here, a single cell proliferation of melanocytes, like in melanoma in situ, but it's not melanoma in situ. It's just melanocytic hyperplasia of chronic sun-damaged skin, and here is also the immunohistochemistry. Sometimes when you excise a melanoma in situ, you get back to report melanoma in situ, but it's not excised in toto. And then you excise another bit and it comes back. There are still single cells and it's not excised in toto. At some point you have to stop and say, this is the normal hyperplasia of melanocytes in this patient. This is also overdiagnosis in some cases. Recurrent nevi, overdiagnosis is possible as melanoma. These cases clinically look challenging. Dermoscopically, they look also challenging, because if you don't know that there was a shave biopsy in advance, you have features of melanoma. Radial lines, it's asymmetric, and there is also a white zone, but the white zone around this recurrent nevus is just the scar. And histopathologically, it looks frightening. You see these single cells and the confluent nests, and if you don't know that this is a recurrent lesion, you are lost as a dermatopathologist. And here you see also a heavy lymphocytic infiltrate, and here's the other part of the lesion, and here you can see the pre-existing nevus. But if the dermatopathologist doesn't know that there was a shave biopsy in advance, he might have difficulties. So for you clinicians, it's important that you make the dermatopathologists know that there was a previous surgery. To avoid overdiagnosis of persistent and recurrent nevi, the clinician and the pathologists are equally responsible, not only the pathologist. Now, what about routine cases, finally? Routine cases are sometimes easy, well, most of the time, in 95%. And easy for me because I'm a dermatopathologist too at the microscope. What should dermatopathologists do? Well, they should learn dermoscopy, and then they avoid over and under diagnosis. And of course, they should ask for images, for clinical images, and you should give them your images. And this is a study that shows you that clinical and dermatoscopic image will help the dermatopathologist to improve his diagnosis, but Jerry published some years ago. But how should dermatopathologists include or integrate the dermatoscopic or clinical information? In every case, only in difficult cases, before or after looking at the slide? Well, how I do it is simple. I first look at the slide, and 95% I don't need any clinical images. But sometimes, if I have doubt, I need it to avoid over and under diagnosis. Example, you have to know where to fall, at the benign side or the malignant side. This case, dermatopathologically, looks like a nevus. Only basal melanocytes, no scatter here also. But this is the case clinically here, and this is the case dermatoscopically. Is this in line with a nevus? No. So what do? I cut deeper levels, and then I see that the lesion looks different here, and I make the diagnosis of a melanoma. Another case, so malignant, melanoma. It saved me from underdiagnosis. This case here looks like a nevus. Here, very small case, nests mainly, and I'm not sure is it a nevus or is it a melanoma, benign or malignant. But this is the case clinically, and this is the case close-up, and this is dermatoscopy. What's your diagnosis? Melanoma, any doubt? No. So also my diagnosis as a histopathologist changes from nevus to melanoma because what I see dermatopathologically is in line with a melanoma. So again, the correlation avoids underdiagnosis. And this case here, dermatopathologically, looks a little bit weird. It's asymmetric. Here are some single cells, here are confluent nests, and this part may look like a nevus. This case has been signed out by the dermatopathologist as a melanoma. But here, when I look at the clinical, close-up, dermatoscopy, baseline and follow-up, is this in line with a melanoma? No, it is a nevus. So the correct diagnosis is a nevus, and this has been overdiagnosis. And overdiagnosis is also common in routine cases. And if you look at the clinical and the dermoscopy as a pathologist, you can also avoid overdiagnosis. Finally, last 3 minutes, there is also an urge for overdiagnosis with regard to new computerized automatic systems. And you know we live in the computer age, and sometimes in the near future we will be replaced by computers. For example, this is a machine you might know. It's Melifind, and there was a study, the performance of Melifind, that has been published in the Archives of Dermatology, and you see the diagnostic accuracy of this machine. It has a sensitivity to detect melanoma of 99%. So from 100 melanomas, it will say in 99 cases it's a melanoma, and it has a specificity of 10%, which means what? From 100 nevi, 90 nevi will be overdiagnosed as a melanoma when you use this machine. Now, why this is a receiver-operator characteristic curve, so it's not so important, but what is important is you can choose any threshold you like. You can choose high sensitivity and low specificity, medium sensitivity, medium specificity, or high specificity and low sensitivity. Well, the producers or the company of Melifind selected high sensitivity, 99%, and low specificity, 10%. Why did they do that? What do you think? Because otherwise they would not get FDA approval. So FDA told them they should have over 95% sensitivity, so they told them between the lines they should overdiagnose because they should not miss a melanoma. Now, this sounds good, but now let's go into practice. This is a patient that you might encounter too, patient with multiple moles. Now let's use the machine with this accuracy in daily life. Now, this is a little bit mathematics, but I hope you can follow me. Suppose we use this threshold of sensitivity 99% and specificity 10% in daily life, and also suppose that the prevalence of the target disease is 0.001%, which means per lesion, not per patient, which means from 10,000 lesions you see, one is a melanoma, yeah? Which is approximately our daily life, yeah? Because we have so many nevi and so few melanoma. What do you think, if you use this machine, how likely, if it comes out from this machine that the lesion is positive, which means it is a melanoma, how likely it is that the lesion actually is a melanoma? What do you think? Is it smaller than 1.0%? Is it 1.0 to 1%, 1 to 10%, 10 to 90%, 90 to 99%, or larger than 99%? Who is for smaller than 1.0%? Some. Who is for 0.1 to 1%? Who is for 1 to 10%? Who is for 10 to 90%? Who is for larger than 90%? And most of you didn't do the calculations. Yeah? But let's do the calculation. This is the final thing I want to show you. If you have 100,000 lesions, yeah, and a prevalence that we said before of 0.01%, only 10 lesions will be melanomas, and the rest will be nevi. Now, if you use the machine with this sensitivity, all melanomas will be diagnosed correctly. But you will have, with a specificity of only 10%, you will have 81,891 lesions, nevi, that will be overdiagnosed as melanomas. So, what is the chance? The chance that a lesion that has been diagnosed as a melanoma by the machine is 10 to more than 80,000, which is smaller than 0.1%. Yeah? So if we use these machines in daily life, we'll have overdiagnosis that we cannot imagine. So this is the correct answer. These machines are Ruby-Goldberg machines. You know what a Ruby-Goldberg machine is? A Ruby-Goldberg machine is a very difficult looking machine that only solves a very simple task. A simple task is whenever you are confronted with a lesion, say it's a melanoma. Yeah? This is the simple task, but also my son could do this. So how to avoid overdiagnosis triggered by fear, because most overdiagnosis is triggered by fear to miss a melanoma. But my advice to clinicians, dermatoscopists, confocalists, and dermatopathologists, and also to all the companies who produce the advices is don't run around like chicken and don't panic. Because if you panic, you're prone to overdiagnosis. And you think that overdiagnosis is not as bad as underdiagnosis? No, because overdiagnosis is more common than underdiagnosis. And many people in Austria and Italy and around the world have diagnosed a melanoma and don't have it. And this is also can change their life. Not only having a melanoma may change your life, but also having a melanoma, but actually not having a melanoma can change one's life. Thanks.